Alrighty, good day to all, and thanks for joining. Throughout the course of 2020, COVID-19 went from being a foreign term to a word adults and children alike use in daily conversations. The disease has changed our societal and familial cultural norms, the way we work, go to school, and even the simplest chores such as buying groceries have been transformed as a result of this global pandemic. BP recognized the potential risks to its workforce and operations imposed by the proliferation of the virus across the country in rapid fashion. While we didn't know the extent at the time, as COVID-19 began emerging in the US as a communicable threat, we acted early, requiring international quarantines in late December of 2019. As with many other operators, our offshore workforce travels from regions across the US, including Alaska and Puerto Rico, as well as international locations. Our philosophy has always been and remains that we will continue to respond in a flexible way to COVID-19, refining quarantine and testing plans as needed in order to maintain a healthy work environment and reduce the transmission among our employees. On February 27th, we made the decision to stand up an incident management team. As like most in the industry, we had a base pandemic response plan comprised of a broad range of tactics. Pictured here are our phase declarations. In the IMT setting, we could bring the collective minds together and refine the plan to meet the demands of COVID-19. IMT needed to refine the why and how behind each of the tactics highlighted in the phase declarations. I'll speak more to some of the tactics throughout this presentation. The bow tie methodology is the tool we most commonly use to define and manage major risk within our operations. This slide depicts the preventative side of our bow tie in its most simplistic form. The opportunity was taken upon onset of the IMT to develop a bow tie with exposure to virus on facility leading to infection of one or more being the top event. This methodology provided the IMT the means to clearly define the threats, the prevention and mitigation barriers, and the consequences. To aid in the bow tie development and support our frontline operations, we brought in additional industrial hygiene and medical support. As well, an infectious disease specialist was brought into the team who provided expert opinion on the virus and insights to the types of barriers needed to be implemented that were above CDC guidance. We monitored media outlets using the real-time scenarios being broadcast as injects such that we would incur during an IMT drill. Events such as the cruise ships not being allowed into port, in turn creating a human petri dish for the virus to propagate, generated thoughts as to how we could manage an outbreak on the asset if state and local authorities would not allow us to transport infectious personnel to shore. Through the bow tie exercise, we broke out the potential modes of transmitting the virus to the offshore assets, such as how we get people and supplies offshore. The first tactic we deployed was standing up a medical team at PHI's helicopter base located in Houma, Louisiana, recognizing this as the primary port of embarkation for the offshore workforce. Screening questionnaires and body temperature scans were implemented based on CDC guidance. A similar line of defense was initiated at all locations where personnel could board a vessel in service of BP. These points stretched from ports in Texas all the way to Alabama. This was an early line of defense that would afford the IMT space to think more strategically and gather additional resources. In rapid succession, offshore crews moved to a 28-28 rotation to reduce the turnover rates at our facilities. Over the coming weeks, IMT and BP internal support staff, in conjunction with the network of contract companies who support BP's business, worked vigorously in updating baseline pandemic response plans to meet the demand of this new strain of coronavirus. We analyzed drawings of the quarter modules on each asset to determine which air handlers supported which areas, allowing us to establish isolation rooms and decontamination zones for medical staff. We reshaped patient care protocols and ascertained the correct level and supply of PPE necessary to manage a field-based outbreak. We researched the best methods to transport large groups of potentially infected persons to shore, such as staging temporary quarter packages on offshore supply vessels, in turn eliminating the exposure to the crew of the offshore supply vessel if mass transport was needed. We had our decon contractors load transport boxes with all the chemicals and equipment necessary for rapid deployment offshore in case of an outbreak. These are just a few of the examples. A few weeks into the IMT, we received notification of a worker displaying symptoms of the virus on one of our facilities. More cases presented themselves in short order. Controls were implemented to effectively segregate the population, including demanning the facility to minimize staffing, implementing rigorous decontamination and disinfection practices, use of strict PPE and social distancing protocols, and twice daily medical assessments of all on board. The minimum manning barrier was applied across all assets until the IMT could gain control of the first wave of offshore cases and establish robust barriers with less reliance on human behavior. We were able to regain control in short order, but the event emphasized that the layers of protection required strengthening. Deeper conversations followed, where we established the necessity to apply a BP-managed 5-day quarantine process and testing protocols prior to traveling offshore. We initiated contracts with hotels in Homa, where we leased the hotels in their entirety, eliminating potential exposure from general public. Cleaning crews came in prior to our arrival, thoroughly decontaminating each hotel. Our infectious disease specialists located a supplier and lab in Pennsylvania that carried PCR and serology tests, which had been approved via the FDA emergency use authorization. The Homa Operations Learning Center, or as some know it, the HOLC, was the point of initial screening and testing for our workforce. We established a drive-through system where personnel entered the parking area, completed the questionnaire with a medical professional who could observe for signs and symptoms, then moved on to a station where a PCR swab was completed, and then finally told which hotel to report to for quarantine. Each hotel had a full complement of both BP staff and medical staff to manage the day-to-day activities. We looked at every possible way to reduce the likelihood of the virus entering the hotels. Some of the things we applied, there were no hotel occupants outside of our workforce allowed. Anyone entering, such as the hotel staff, the IMT staff, catering, went through a questionnaire and a temp check by medical before entering. Social distancing, PPE, and hygiene requirements were enforced on all entering the hotel. Food service from local catering provider was sourced, and BP Health conducted a thorough review of the caterer's infectious disease control program with continuous self-verifications, assuring that their practices maintained a solid barrier. Once personnel checked in, they could not leave the hotel until an hour before flight time. Sort of like the old song, the Hotel California. You can check in, but you never check out. We had to define mechanisms to easily identify who checked in, who passed all testing, and who was cleared to fly. Various color armbands, like those used in amusement parks, were issued to denote each level of clearance. We implemented daily temp checks along with a set of base questions to test if anyone had symptoms arise from the previous evening. Early PCR testing came with logistical challenge. We would have to pack all the samples in coolers and charter a flight to deliver them to the Pennsylvania lab. In general, we received results within 72 hours of arrival at the lab. Persons with positive results were contacted by our physician to discuss those results, investigate the possible time of the exposure, and determine if there were any close contacts with others while in quarantine. Upon release of the employee, a hotel lockdown was initiated, allowing time for a cleaning crew to decon all general areas and the employee's hotel room. As a verification of cleanliness, fluorescent marking gel was placed on predetermined objects within the room. The group of objects were chosen based on information regarding the contamination of these surfaces with communicable disease pathogens, as well as consideration of the likelihood each would be touched during routine occupation of the space without the occupant performing hand hygiene prior to using these items. Black lights were scanned across the gel after cleaning operations to verify that objects had been effectively cleaned, and feedback was provided to the cleaning staff. BP Medical case managed the BP employees directly and maintained contact with contractor reps for all others. Return to work requirements were based on CDC guidance. Various obstacles arose through the first few months. Some personnel carpool to work, while other companies used people haulers to transport crews. Everyone in the vehicle would be considered a close contact and had to be sent home if one occupant displayed signs or symptoms or failed the testing. We communicated this risk across our workforce and requested those using people haulers to implement barriers such as deconning the transport vehicle prior to use, separating personnel as much as possible, and use of PPE. As well, we maintained a transport vehicle to move these groups from the hotel to the heliport. On occasion, some would not travel directly to the hotel after completing the initial assessment at the HOLC, or from the hotel to the heliport. So we had to establish time limits for travel between each point, make everyone aware of those time limits, and then monitor it accordingly. We established protocols for managing COVID risk at the heliport in conjunction with PHI. All PHI staff and supporting workforce were screened daily. Social distancing, hygiene, and PPE standards were implemented. Flight schedules were shifted to minimize the number of personnel sitting in the waiting area. Non-BP operated rigs were not part of the quarantine and testing strategy. This led us to separate the BP operated and non-operated asset flight schedule to eliminate cross-contamination potential. Helicopter common areas and helicopters were deconned between rig and platform crew changes and every night. The last threat mechanism we had to define barriers for were third-party companies and/or regulators who could arrive at the asset and a helicopter other than our PHI flights. A few risk discussions took place with each of these, and each group understood and agreed it was in everyone's best interest to apply the controls or find remote mechanisms to conduct the necessary task. Here we have a simplistic view of our escalation barriers. A person under investigation, or PUI, on board kicked us into a phase 1.5, which wasn't listed in our phase declarations, but basically it is phase 2 protocols without a reduction in POB. The biggest test of our escalation barriers arose when a worker displayed symptoms of the virus on the asset. The facility was in preparation for a full facility shutdown, with major construction activities planned once the facility was safed out. The facility was at full capacity for persons on board, along with a flotel operation housing an additional 80+ workers who transferred by personnel basket to and from the facility twice a day. The facility team immediately enacted phase 2 protocols on the facility and flotel while awaiting test results on the person under investigation. In preparation for test results, the STOP team and HSC team developed a plan to include flying nurses to the facility and the flotel to perform on-site PCR testing of all on board if the results from the person under investigation came back positive. Test results were positive, and the on-site testing plan was enacted. The results returned a 0 infection rate, demonstrating escalation barriers were effective. The medical community was engaged, and adjustments were made to our quarantine testing strategy based on the positive person reaching offshore after the 5 days of quarantining and testing. Through these conversations, we decided it was best to shift the PCR testing to the morning of day 4 in quarantine and do serology tests on day 1. Day 4 PCR testing provided an additional time for the virus to incubate once in quarantine, in turn, increasing the likelihood of preventing the spread of the virus to our facilities. Weather has been a challenge, considering we have had 10 named storms and/or hurricanes in the Gulf of Mexico this year, and she hasn't stopped yet. Maintaining quarantine of 100% of the workforce proved to be a monumental task, with the storm trajectories shifting so erratically, along with the storms affecting our workforce's homes. We had to make a shift to overcome this hurdle. Non-essentials who left quarantine to tend to their homes and family would return to quarantine once the storm cleared. We began sending only ops essential workforce back offshore immediately upon return, and they were the only ones on site for the first 5 days. These 5 days were effectively quarantining them on the asset. During these days, they followed the barriers listed under our phase 2 declaration. On day 5, we flew nurses to the facility and performed on-site PCR testing. We would expedite those results and be able to initial full remand on day 6, provided there were no positive cases. This tactic proved successful each time we have applied it. Over the next several months, BP was able to incrementally increase the personnel working on each of the BP operated facilities while effectively controlling the top event defined in our bow tie. The stringent application and oversight established confidence in the preventive barriers, both onshore and offshore. A new normal operating philosophy had emerged, and the need for an active IMT was no longer necessary. In order to continue application of the quarantine and testing protocols established by the IMT, an ongoing ops team called the STOP team was established. The organizational structure of the STOP team was made up primarily of select members of the IMT team who carried the deep understanding of the tactics applied during the previous 4 months. The shift out of IMT provided a rich environment to apply elements of a continued improvement process across all the facets of the response employed since late February. Considering the current market, the STOP team eagerly dissected process application to determine how to reduce the cost burden, yet maintain and or increase the level of barrier strength developed since the introduction of the virus. The BP Industrial Hygiene team conducted training sessions with the hotel cleaning staff so they could reinstitute general disinfection of common areas and rooms of non-infectious persons. This education eliminated the need for general disinfection being conducted by decontamination teams, effectively reducing costs and streamlining the process. We also shifted from using the lab in Pennsylvania to a local lab for analysis of our PCR samples. So this slide is just a quick review of our barrier progression and strength. Of course, we start off knowing our threat as the virus in the environment. We applied the 28-28 barrier quickly to reduce the amount of change out on the asset. We were requesting everyone to follow a 14-day self-quarantine barrier. Again, this was early on in the onset of the virus. What we quickly learned was that it requires discipline and it wasn't working very well. We added in the testing and quarantine process. Initial onset was that we would do the PCR testing on day 1 along with the questionnaire. The initial serology, initially we used serology on day 5. And then medical data told us best to shift the PCR to the end of quarantine and use serology up front. And that gave us the ability to catch those infected 7 days plus before coming into quarantine, and also see if people had antibodies built up, and provided a time for us to ask more questions and build more data. Since we made this shift, we haven't had any positive cases offshore. Of course, we have the hotel quarantine and PCR testing. So the response and management of COVID-19 is dynamic and requires staying engaged with new technology while ensuring rigor in assurance and verification of the barriers. There has been a focused effort on the mental well-being of our workforce, as these times have created a new type of stress on individuals and their families. Managing the mental well-being of our people remains the focus of the continuous improvement process, as well as the use of new forms of technology for testing and contact tracing, which are being piloted to provide rapid turnaround of individuals to a test and go process, while maintaining a high degree of confidence in preventing the infection and spread of COVID-19. Hopefully, in the first quarter of 2021, we'll be able to procure point of service testing media and equipment that achieves high specificity, high sensitivity, and can be implemented on the assets. After careful consideration and review acquired over the last 8 months of data, yesterday, we implemented a 1-day quarantine pilot for a small group of operations critical personnel. Essentially, we moved a portion of the prevention barriers previously managed through hotel quarantine to the offshore asset. Doing this carried a load of logistical challenges and weighs heavy on personal accountability for success. From onset through present, the primary threat we all face is the virus in the environment. and the fact that most barriers against it rely on human behavior, such as isolation, social distancing, hygiene, and donning of PPE. Some struggle with the notion that the pre-mentioned infringes on their right to maintain their civil liberties and freedom. But we must be cognizant of our fellow people and remember what it means to be an advocate of each other's well-being. Moving to the one-day quarantine, deep conversations have taken place with our workforce, highlighting that each person must recognize that failure to protect themselves and others following the CDC guidance, along with our offshore quarantine requirements listed in the one-day quarantine program, will inevitably lead to greater numbers of offshore community testing positive for the virus. These practices should take place both at work and at home. Whether or not we have an outbreak on our offshore assets through this process and have to pull back on the one-day quarantine strategy is dependent on one thing, and that is the personal accountability of all involved in the program to protect themselves and others, not only on the asset, but in our personal lives. We are all in this together and have a shared responsibility to keep our work and home community safe. We would much rather control the spread by everyone living responsibly, helping to keep our coworkers safe, and engaging the continual progression of our plan to shift out of the 28-day rotation. That's the conclusion of my presentation. I have added my email address into my speaker bio. Feel free to send questions and I will reply accordingly. It was a pleasure to present to you all, and thank you for attending.